Thank you all for coming. Some of you are familiar faces, and I appreciate you coming out. And hopefully, some of this may be sort of review stuff for you, but maybe there's some new things and some topics for discussion. But the topic I was asked to focus on is non-muscle invasive bladder cancer, and I think we're having another speaker do muscle invasive bladder cancer after this. So just some topics of what I'll cover, a little bit about the epidemiology or the statistics about it, and then we'll talk a little bit about diagnosis and treatment, and then the surveillance strategies involved with non-muscle invasive bladder cancer. So in terms of bladder cancer in general, about over 70,000 cases are diagnosed annually in the U.S. alone. And that translates to about a 1 in 28 lifetime risk for developing bladder cancer. And they noticed over the last 3 decades that this rate is increasing a little bit. But with improved treatments and more early diagnosis, the death rate from bladder cancer is declining. Fortunately, 75 to 80% of the tumors that we diagnose are non-muscle invasive and offer a better chance at treatment. So with these treatments, if you look at any point in time in the United States, there's 580,000 survivors of bladder cancer at any one time. So bladder cancer is typically diagnosed in patients that are 55 or older, but you do occasionally see it in people who are younger. It's more common in men, and some of the risk factors are smoking or exposure to some industrial carcinogens. If you have a chronic catheter in your bladder, that may be associated with cancer. An old pain medicine, phenacetin, which is no longer available, or a history of certain types of chemotherapy. So just some background on the definition. So non-muscle invasive bladder cancer refers to bladder tumors that have not yet invaded the muscle layer of the bladder. So I use this diagram below to just illustrate that a little bit. If we were to say this is the innermost lining of the bladder, and that's called the mucosa, and then this below this is what we call the submucosa. So we're dealing with all the stuff, all the tumors in here that don't yet get to this layer, which is the muscle. And the significance of it entering the muscle is that the bladder tumor now has access to blood vessels and lymph channels that it didn't have in the more these more superficial layers, and so the treatment is radically different once it gets to the muscle. So just to reiterate, so the stages that are involved in non-muscle invasive are CIS, TA, and T1, and those correspond to these over here. CIS is an unusual entity in that it's superficial, but it can often be very aggressive because the cells are high grade. But there's a wide spectrum alone, even in just the CIS. So within non-muscle invasive bladder cancers, there is a wide spectrum of tumors, and based on that, there's a wide array of recurrence risk and risk of progression, and I use these diagrams just to illustrate this. So here we're looking at a study that included 1,400 patients, and they included only patients who had a low-grade, low-stage tumor, and I'll talk about grade and stage a little bit more. But here we're talking about the probability of being without recurrence over time. So here everybody starts and they get treated, they have no recurrence, so they start at 1. But through time, and time is denoted down here in the number of months, so out here is 10 years. So the recurrence risk is about 40%, because 60% live without recurrence, so 40% still recur even though they have a low-grade, low-stage tumor. And then if you look at people who may be at more of an intermediate risk, even though they have low-grade tumor, perhaps they have a large tumor or multiple tumors in their bladder, their recurrence rate is even higher. So at 10 years, they're at 60% of them have recurred, and it may be recurrence just in the inner layers of the bladder, but it's still a recurrence. So 60% recurrence here and 40%, and they were all just low-grade tumors to begin with. But fortunately, for these type of tumors, the progression is very low. See out here is progression. By progression, I mean it's getting access to those other layers, or it's becoming a higher grade tumor. And so for it to progress to muscle invasion, where we talk about radically different treatments, it's only about 5%. Now, if we flip the tables and we look at the recurrence risk in patients who have high-grade disease, so those are high-grade but still superficial tumors, the recurrence rate is much higher. So this graph is taken from a different paper, so it's flipped around. So this time we're looking at the recurrence. So as you get more recurrence, this number starts to go up. So you can see the recurrence for high-grade tumors is higher. So even at 5 years, your recurrence is already above 60% if you do nothing. And then they add some other dimensions to this, the high grade. This gray bar and everything below it, including this dark band, represents the people who progressed. So they progressed in their stage. Either they came from a superficial to a T1 or they got into muscle. And so you can see the rate of progression is higher with high grade disease. And this last one is people who actually go on to die from their bladder cancer because it progressed. So that's why when you have high grade tumor, it may not just be enough to scrape the tumor off the bladder. You may need other treatments, irrigations in the bladder to help reduce this recurrence and reduce this progression. So using those as sort of a background, that illustrates the importance of diagnosis, because our main goal of diagnosis is to figure out who can best be treated with simply just resecting it and watching the bladder, who could be treated with removing the tumor and then adding some chemicals that you put in the bladder that's called intravesical chemotherapy, or who would benefit most from just taking out the bladder or doing systemic chemotherapy and radiation. And that's the talk that's going to happen later today. So just some background on diagnosis, and when we think about diagnosis, we also talk about screening. So these are people who don't have any symptoms of bladder cancer, and so how do we screen them? So people who have blood that they can see in their urine without any other cause, like they didn't have an injury or an infection or a stone, they should be evaluated for bladder cancer, and that may include looking for cancer cells in the urine or looking in the bladder with a scope. And maybe also looking with a CAT scan. And then also people who they submit a urine to their office and the doctor calls and says they found blood cells in the urine. That's called microscopic hematuria because it's blood you can't see. And so if the AUA guidelines have recently changed, it used to be that they had to be in 2 out of 3, but we know now that bladder cancers behave. Sometimes they bleed and sometimes they don't. So now they recommend doing further testing if you only have one urine sample that has 3 or more blood cells in it. And then also this other category is people who have persistent irritation in their bladder and there's not a good reason why. They're not infected, they don't have any other cause. One of those causes could be an irritating bladder cancer, and so they recommend screening in those people. But there are some pitfalls to our original screening. Sometimes you'll hear your urine test is positive on a urine dip, but that could be positive without having blood cells in the urine, and that's not true blood in the urine, so that's what that means. And then urinary infection can cause blood in the urine and not be a cancer. Somebody who's got chronic kidney disease may test positive for blood. Or if you've had a recent scope or some other catheter or even a bladder chemotherapy agent could cause some blood in the urine. So once we have suspicion, and often you do a scope in the office, you may find a lesion or the cells may be abnormal. What this shows is what's called a transurethral resection of the bladder tumor, and you can see the lesion up there. I don't know, maybe we have a pointer there. So there's the lesion, and you scrape it off. This is a loop that goes through the scope, and this is just a hot wire, and allows us to scrape it off, and then you have this crater here on the wall of the bladder afterwards. So from these scraping specimens, we can learn more about the tumor that we're dealing with. So one of the pieces of information we get is what's the grade or how aggressive does the tumor act. And this is a term basically used to describe what the pathologist guesses based on what the cells look like. So they stain them and they say, well, these cells look very ordered, and so we're going to call this a low-grade tumor. So this is the lining of the bladder, that innermost layer, and then this is the lining just underneath that innermost lining. And then, so low-grade cancers, as we showed on the recurrence and the progression, they may be treated with resection and surveillance. Some of them, if they have more higher risk features, then you may end up getting some bladder intravesical therapy as well. Where the bottom picture shows high-grade tumor, and this will more often require additional treatment like BCG or mitomycin, stuff like that, because of the danger which I showed in that first couple of slides that that could progress. So just to kind of review the staging again, here these three are sort of the non-muscle invasive bladder cancer, and so we include the ones that and just that innermost lining, the mucosa, and then the submucosa or the layer just below it is this one here. And this is the one, that strange one that acts as high grade, but it's still just in the superficial lining. So there are some other factors that we might use to help predict the course of the tumor. If you have a tumor that's large in size, some people use greater than 3 centimeters as a cutoff, you may have a higher risk of recurring or progressing. So this may spur one to do additional therapies. Again, if you treat the tumor by scraping it off and 3 months later you look in and you have another tumor, it may be a sign that you need additional treatments. And then this is a term used to describe swelling of the kidney, and what happens there is the tube that drains the kidney connects to the bladder, and if you have swelling, it suggests that maybe the tumor is invading into the muscle and causing blockage of that tube. So it suggests that you may need further staging to make sure that it's a non-muscle invasive bladder cancer. Somebody who has more than one tumor in the bladder may be more likely to recur. And then these two are given to us by the pathologist. They'll look at the cells and they'll say, well, this one is in a lymph vessel, has a cancer cell there, or the pattern of the cells may be different, and these two suggest that a tumor is more likely to spread to lymph nodes or blood vessels or metastasize, and so these ones may be better served with more aggressive therapies. In addition to those, we also talk about what's called a restaging resection. So for a high-grade tumor that's a T1, we want to make sure that it's not in the muscle. So a couple weeks after you recover from resection, they may talk about a restaging resection of the tumor, and that's to ensure that there's no muscle. It's a better prognostic sign if they scrape it and they don't see any more tumor. It may be somewhere in the middle if you scrape it again and there's still more tumor, but it's not in the muscle. So, and then there's a couple of gene expressions, and there's more out there covered in urine tests and other things. But these two are thought to maybe play a role in prognosis in trying to determine which ones are more likely to progress or recur more aggressively. And so this P53 gene is it's like a shopkeeping gene. So if there's something wrong with the DNA in the cell, this protein's supposed to turn on and cause the cell to die so it doesn't turn into something bad. But when you get a problem in this gene, it gets overexpressed, and we can test that in either the tissue that we get or in the urine that we test. And this is also sort of a cell cycle regulator, and when the cell's told to divide, this kind of revs up and causes it to divide more. And it's thought that with overexpression, this is just a graph again showing, so these are the people who had bladder tumor, and over time they looked to see how many remained free of tumor progressing to a worse stage. And when they didn't have this mutation, they had less progression than when they did. So what is intravesical therapy? So again, we would select patients for this treatment based on whether they have an increased risk of recurrence or progression. This is just a cartoon showing a catheter going into the bladder, and the medication gets instilled in the bladder, and it maybe something where you keep the chemicals in there an hour or so and then you pee it out and go home, and you may repeat this one time a week for several weeks. The types of therapy in the bladder can be divided broadly into two categories: the chemotherapy and the immunotherapy. So one of the most common intravesical chemotherapies that we use in bladder cancer in this country is mitomycin C. It's an actual chemotherapy agent that in certain cancers we give IV, but here we give it in the bladder. And because we give it in the bladder, it has less systemic side effects. It's a big molecule. It's rarely ever absorbed through the bladder. In some cases, during scraping of the tumor, if we feel that it gets a bigger tumor and we know it's bladder cancer, we can give a dose of mitomycin C right after the resection. And there are some studies that suggest that maybe the early recurrence is reduced a little bit, but the long-term recurrence risk is probably not altered that much. And then a different way to give it is what we call an induction course, and that's where you come in and you give a treatment once a week for 6 to 8 weeks. And then some people give a maintenance program where you give one treatment per month for about 12 months. And certain multiple low-grade tumors or high-grade tumors, mitomycin may reduce the recurrence risk at least by 20% or so. It hasn't been shown to prevent progression in high-grade tumors or in what we call the CIS, or the carcinoma in situ. So again, going back to side effects, because it's large and it's in the bladder, its systemic effects are very rare, but people notice they may get burning with urination, urgency, frequency, or pain down there. That's something that's cumulative. You get more doses, and it seems to be more irritating as you get more doses. Then one other important thing, and this goes back to, well, can you give it one dose after you scrape the tumor? If you have a hole in the bladder, when you scrape it, and sometimes a hole in the bladder doesn't cause any problems. It's something we can't see, but it may still have a small leak. If the mitomycin gets in through that hole and gets in the belly, it can be very irritating to the bowels and cause severe abdominal pain. So you have to be careful and choose the right people that you use to give that one dose of mitomycin C after your resection. And so there are some newer trials out, comparing how can we improve the results of mitomycin C. Higher concentrations of either 40 milligrams and 40 mLs, or maybe even 40 milligrams and 20 mLs, rather than 20 and 40, may have a better efficacy. I think right now we're using 40 milligrams in either 40 or 20 cc's at Carmanos. And if you alkalinize the urine, so here we're talking about taking some bicarbonate pills both before, like the night before and the day of treatment, it may improve. And then also dehydration, so just stopping all your fluid intake the night before, and then you come in. And the idea is that you're not having as much urine in your bladder being made when you get the treatment, so your bladder sees a higher dose, because it's going to be diluted by the urine as soon as you put it in. But also along that point, it's good to make sure that you have an empty bladder before you give the agent. So you put in the catheter and either drain it, or you ask the person to pee before you give the mitomycin C. So there are some other chemotherapy agents available. Valrubicin is the Valstar. It looks orange. It was initially approved for BCG refractory disease, and in some patients you can get a complete response from this who would otherwise be a candidate for cystectomy. So it may be an option in somebody who's got high-grade disease that didn't respond to some other treatment, and you're giving this treatment to see if they'll respond to that. Gemcitabine is a newer one that's out. It's I think availability will become more common. It's actually made to look like one of the molecules we use to build DNA, and that's how it interrupts DNA synthesis. And it can be used for, again, the people who don't respond to BCG, which I'll talk to in a minute. That's an immune therapy, which we commonly use for high-grade bladder cancer, may respond to this. And so there's been a lot of studies, and I just kind of put it up there to just kind of illustrate some of the new studies. And here they're comparing gemcitabine to nothing, and here they had a similar recurrence. But then you compare it to mitomycin C, and it was, the same or maybe a little worse, but then it was a little better than BCG. So it's a little bit over kind of all around the place. So I think the data is still maturing on whether this is going to be helpful, but it provides another option for somebody who maybe didn't respond to some of the other treatments. So this is, again, one study that looked at a series of patients who were treated with gemcitabine, and they included basically all these patients that had BCG beforehand, and either they stopped it because they couldn't tolerate it, or they had 37 of them who had their tumor come back despite the BCG. And so they had initially 27 of these patients had complete response to their tumors. 19, despite given 6 weeks of this treatment, still had tumors after, and then 20 had basically no response. Either the tumor got worse or the tumors were exactly the same. Here it was given 2 times a week for 6 weeks, which is a little bit different from some of the other ones. So here we're looking at, again, recurrence over time. So the higher the graph, the more recurrence you have. The dashed line is the people who did not have the dashed line is the people who didn't respond to BCG, and this one was the ones who couldn't tolerate BCG. So the ones who didn't respond to BCG usually are more aggressive tumors or a little bit higher grade. And but even in these, still you had some at least delay in recurrence, and some people didn't recur at all yet. So it does have some response, but still we're talking about maybe 20 to 30% respond that didn't respond to something else before. So then we go on to immune therapy, and the most common immune therapy is the BCG. And what that is basically it's a bacteria that's similar to TB. But it's sort of attenuated, means it's knocked down, so it's not actually like giving you TB. But it's considered the first-line treatment for that one type I was talking about, the CIS, or the carcinoma in situ, which is very high-grade and aggressive cells that are only on the inner lining of the bladder. The main concern of this is avoiding systemic absorption, because it can cause problems, and it's still a bacteria, so it can cause infection. So in order to give this, we wait at least 2-3 weeks, sometimes 4 weeks before we give it, to allow things to heal, because if you have a new scrape in the bladder, it's more likely to absorb it into the bloodstream. It's given as an induction course. You give it 1 time a week for 6 weeks, and then typically after that you'll wait about 6 weeks and do a confirmatory biopsy, and that's where you go back and you get biopsies of the bladder a lot of times in the operating room to just make sure that you did respond to the BCG. And then once you do respond, then you go on to maintenance, and that would be once weekly for a 3-week course. And there are a wide range of different schedules for this BCG maintenance. One of the largest groups, the Southwestern Oncology Group, goes with one at 3, one at 6, and then every 6 months for 2 to 3 years. And BCG has been shown to decrease the rate of recurrence and also decrease the rate of progression. So side effects of this, from getting the BCG, you can get fever sometimes. Sometimes this may just be a plain old urinary infection from having a catheter put in, or irritation, or an exaggerated immune response to the BCG. But sometimes it can be what's called BCG sepsis, which fortunately is rare, but in somebody who's susceptible, who might be on chronic steroids or might be immunosuppressed somehow, they may be more susceptible to this, so we have to try and stay away from BCG in this situation. But it can be marked by high fevers, and it may require a prolonged treatment with anti-TB medicines. So it's something that we watch out for. As with the other treatments that we give for bladder irrigation, there can be some irritative bladder symptoms that can worsen over time as you get more and more doses. So I just put this up here as sort of a take-home. This top one is, this is basically a summary, this is a study summarizing all studies. And this is a line that represents a line that says that, okay, having this treatment versus not having this treatment is exactly the same. So if your dot is on this line, then it means that they're the same. So this represents accumulation of all the data of these studies into this point here. And so this top part is people who had maintenance compared to no treatment at all. And people who had maintenance so were on this side. So they were, because the dot is on this side, they tended to do better. That's basically what it's saying. The recurrence is less. Whereas the recurrence in patients with no maintenance versus no treatment, you see how it's on the dots on the line. So it suggests that maybe we may be doing something with maintenance, and that it may be important to overall treatment down the road. So another immunotherapy is interferon, and this is basically something that we normally have in our immune system anyways, and it's used to help kind of rev up the immune system to attack the bladder. And a lot of times it's used now in patients to help the response with BCG. And so there's a certain amount of patients who don't respond to BCG who may respond to BCG and interferon. But again, we're talking about probably a small subset of patients. So we talked about some of the chemotherapy and immunotherapy agents that are available now, and some other things that have been proposed as new ones. So I put gemcitabine here also because it's sort of newer, but it's becoming more available, or it will be soon. And then docetaxel is another chemotherapy agent. And again, we're trying to hit those patients who don't respond to the BCG. So, BCG is sort of our best treatment for these high-grade superficial bladder tumors. And when they don't respond, you either have to offer a more aggressive therapy, which may be removing the bladder, chemotherapy and radiation, or you may try one of these things first. And then we talk about there's different ways to try and improve the effect of these medications, and so they've attached them to things like nanoparticles or other proteins to help get the tumor or the chemotherapy molecules to attack the tumor cells. So here just using some graphs again to illustrate that. So here we're talking in patients who had a recurrence after the BCG. So these are high-risk patients who may need removal of their bladder if they don't try these other things. And over time, we're looking at recurrence. So this is recurrence-free survival. So this is life without recurrence. So as you go through time on this side, the graph goes down as people recur. So, but again, the hope is that you can delay recurrence, and still at 12 months you have 50% who haven't recurred yet. And then at 2 years, the recurrence becomes more. And then long term, you get to maybe a quarter of the patients don't eventually recur. And then we talk about survival for bladder cancer. And overall, long term, it's pretty good. So still above 75% at the 3-year interval, which is where they had enough patients to really tell whether it's making a difference. So this is an agent that's kind of old but new, and they're using it. It inhibits growth of blood vessels, and it may actually be used to improve the response of mitomycin C. This was studied in mice, so it still has a long way to go. And then this one here, meglumine gamma leuconic acid, is it's a sort of an agent that's very toxic to cells, and so we talk about free radicals and oxidation, so it attacks the cells in the bladder, and bladder cancer cells may be more susceptible than normal bladder cells. And so we're again dealing with recurrent bladder cancer, and they showed a 43% response with a 30% partial response rate, and may also be able to combine this with another chemotherapy agent, epirubicin, which I showed before, and may help improve that. So this one is kind of like a next generation mitomycin C, and so it looks a little bit like it, it's being used again in people who've failed their first therapy, so in people who've recurred despite therapy, and it shows a recurrence-free survival rate of about 39% at 2 years, and that's similar to what that graph I was showing before with the docetaxel. We're somewhere around anywhere from 40 to 50% at 2 years recur, so this is very similar. But because it looks like mitomycin C, it's going to have sort of the similar side effect profile of irritation of the bladder, but theoretically less systemic side effects because its absorption rate is even less. So in the immunotherapy world, this is just an illustration of how immunotherapy works and what we might be able to do to kind of come up with new ideas to help the immune cells or the immune system attack the bladder cancer cells. So basically, BCG stimulates sort of our scavenger cells to find the bladder cancer cells. And it stimulates these, and once these get revved up, they send out messengers, and these stimulate other cells to stimulate the immune system. We want the immune system to go this way and stimulate these cells rather than this way. This is more of you've got a bacterial infection, and it secretes antibodies, and it wants to attack the bacteria. But this is where the cells are eating the tumors. And so one way is to block this enzyme, because what this does is it blocks the pathway from going down to these cells and off to the tumor-eating cells and directs the immune response to the antibody way. So if we can knock this out, then maybe even just in the bladder, then maybe we have a new immunotherapy. And then also these two guys here, IL-2 and IL-12, this IL stands for interleukin, which is, again, stimulates immune cells. These two molecules sort of rev up these tumor-eating cells. And so that's the idea, is that we want these cells to go and attack the bladder cancer cells. So the mycobacterial cell wall has been looked at. The idea here is that we want to try and have something that's like BCG, but it's not absorbed and doesn't cause BCG sepsis. So if you use a wall, then maybe you won't have, cause an infection. So this had a lot of studies a few years ago, but I've seen less lately, and part of that is, I wonder if maybe the success isn't quite as what it has been told. But the idea, I think, is still good, and I think finding some component of the BCG that will allow us to treat the bladder cancer without having the side effects is still a useful concept to go after. The other thing they talk about here is that it may also have a chemotherapy-like response to the bladder cancer cells as well as an immune response. And so it's sort of unique in that way. So these are just some other ideas that came up with immunotherapies, and one is actually a staph bacteria, toxin on the cell wall in the staph that may rev up the immune system in the bladder, DNA vaccines. So these are experimental. The data is not very good on these yet. And then the other thing is combination of agents is a concept that's being used more. So you fail one treatment, you may combine that treatment with another thing. And one of the common ones you see is BCG and interferon. So you get that 6 weeks of BCG, and then you go and get your biopsy, and you find you have more tumor. So you can either decide, well, I want to have a cystectomy, or you can try other treatments. And it'll depend on a lot of other information too. It depends on the recurrence that you find. But you may add BCG and interferon. Maybe get the interferon to rev up the BCG response. So then you talk about doing things in sequence. So you recur after one treatment, then you go to a different agent, maybe mitomycin C or Valstar, and you get a response for that for a while, and then you recur after that, and then you try the BCG again, and you get more time without progression. So And then adding 2 different chemotherapy agents, much like we do with cancers where we do IV chemotherapy, we use more than one treatment. So the concept is here is being applied to the bladder and using mitomycin plus gemcitabine. So, and then there may be better ways to make the tumor or the chemotherapy agent more active in the bladder. Thermotherapy, where you're using a catheter to just sort of warm the urine a little bit or warm the agent and allow it to be better absorbed into the bladder to have a greater effect. And then similarly, you could create electrical gradient. And then photodynamic therapy, washing the bladder with a light-sensitive material that latches onto the bladder cancer cells, and then you give them a special light and may augment treatment with chemotherapy. And then gene therapy, maybe a therapy down the road. So one other important concept with bladder cancer, again, is surveillance. Because as I showed in the slides in the beginning, there's a fairly high rate of recurrence, and so for most low-grade tumors, it stops at recurrence. There's only a small portion that progress, but for high grades, we have to worry even more that this may get on to more aggressive stages. So surveillance is a very key component of non-muscle invasive bladder cancer, and so you want to tailor your follow-up a little bit based on what you think the risk is. Is it a small 2-centimeter tumor, or is it multiple tumors and high grade? And so that's going to affect how you follow up. But a typical regimen may be you come in every 3 months for the first 2 years, and then that's pretty aggressive, probably the most conservative regimen. You may be getting cytologies, urines, a look in the bladder, and then if you have no recurrence after a couple of years, then you may go to every 6 months for 3 to 5 years, and then maybe yearly after that. Also getting periodic images of the kidneys and the tubes that go down to the bladder, because you have the same cells that are in your bladder go all the way up to your kidneys. So occasionally, even though the recurrence from going up from the bladder to the kidney is lower, you every once in a while want to follow those too. So in conclusion, non-muscle invasive bladder cancer represents a variety of cancers with varying risks of recurrence and progression. Proper diagnosis and follow-up can help direct therapy to reduce recurrence and progression. And a variety of intravesical therapies exist to help us reduce the recurrence and progression. Thank you.